My name is Dr. Keisha Callens. I'm an OBGYN. I am bringing you greetings this morning from Georgia. I'm actually in Twiggs County, which is the geographic center of our state and one of our rural communities. And I'm an OBGYN. Figured out if I could just focus on my moms and grandmas, and I got them feeling good about themselves, physically, emotionally, spiritually, then they could do all the magical things they do with their family and their community. And so I've been happy to practice primarily in rural communities for most of my practice. And
Hi, my name is Renee Mitchell. I'm from Brooklyn, New York. I'm a person with lived experience that had many challenges and overcame them and built a foundation for me and my family. I'm also a founder of my own nonprofit called Breaking the Cycle Drop Corp, where I actually deal with vulnerable people and unhoused homeless people, people with addiction, mental illness. I'm also running for office to fight for these same people so that we can get policies in the state legislature. I also work for Kennedy's presidential campaign. I've also have connections with MAHA and medical freedom.
Yeah. So good morning, everybody. My name is Denise Octavia Smith. I bring you greetings from Hartford, Connecticut. I'm a community health worker, the inaugural executive director of the National Association of Community Health Workers. I know I'm here because of my mom and my grandmom, and I know we're going to get to that at some point. So that's why I'm literally here. I've had an interesting leadership journey as a person with lived experience. And I think our voices have become central because we walk with and live with the solutions that our systems and our society need.
My name is Alexandra. I am based in New York, but by way of Texas and Louisiana. So a little bit of lived in family experience there. I'm a policy consultant by trade, but I also do some digital work with political communications and digital media as well. So I think I'm here to kind of share that perspective from that lens, as well as being kind of like a Gen Z 26-year-old navigating this weird time that we're in too.
Good morning, everyone. This is my first time being on anything of this magnitude, so you have to forgive my nervousness, but I am a CHW lead here in Baltimore, Maryland. Happily thriving here. Love it so much. Working one-on-one with our patients every day. If we know what we do, you know what we do. I believe I'm here because lived experience is the new expertise, and that's what I have. So I'm excited to speak.
Hi, my name is Jasenia Muhammad. I was a Kennedy supporter because I'm really into the health movement in terms of informed consent and freedom to choose. I'm a mother of two. I have one, my children are 19 years apart. So my older daughter had in some vaccines, and my younger daughter, I chose not to vaccinate her at all because I felt like, based on my information and what I had looked, I wanted to have the freedom to be able to choose, and I chose not to have any for her. So I am definitely watching all the things that are going on right now with the Secretary of Health and Human Services. I do like the way that direction in which it's going because I think it gives parents and people more choice in their health care. And I just think that that's the most important thing.
Hey again, y'all. My name is MacKenzie Isaac, but friends call me Kinsey, so you can call me Kinsey. Right now, I am tuning in from Oxford, UK, where I'm getting my PhD in bioethics. I specialize in looking at binge eating disorder and other stigmatized mental health conditions in Black adolescents. I want to do everything I can to pour into young people in a way that I know that I needed 10 years ago and that I continue to need now.
All right. So let's open by talking about how the health system has served you. What has your experience been dealing with the healthcare system as a patient? Where does it work? Where does it fall short? I wonder if I might start with Tribeca. No, I'm not going to do that to you because I know you're a little bit nervous. But if you want to, I can start with you. Do you want to start? Okay. Why don't we start with Tribeca?
Yeah, so how the healthcare system has benefited me. Uh, Something to really think about. I feel like when I was younger, I didn't understand the magnitude of what the healthcare system did for anybody. So felt like I had the best doctor, the best advice. Felt like my needs were always being met. And it wasn't until I became an adolescent, started to want to understand my body. I wanted to understand things going on around me, determining my health, essentially. And when I didn't get any of that, um, I knew something was either wrong or needed to be changed. For me, that sparked my fire for becoming a CHW later on, but always advocating for those around me. I don't feel like the healthcare system has benefited me much, to be honest. With that being said,
When you say you weren't getting what you needed, do you remember how that showed up for you? Like, in what ways do you remember not getting what you needed?
I remember my mom struggled with addiction growing up. So I remember needing to have a lot of conversations about puberty and understanding a period and hormones, things like that, because I wasn't getting those things at home. I would ask my doctor, it would become a more of a concern on, was I having sex? Was I making immature decisions? Was I being irresponsible with my body? And none of those things were the case. It was a simple Q&A and a simple uh, moment of being needing to be met with dignity, and I wasn't. So it showed up for me in a dark, scary, confusing way.
Keisha, I might come to you next. What goes through your mind when you hear that? And do you have any similar stories from being a patient? I know you're a provider, but as a patient, as a Black woman.
So thank you. And Tribeca, are you crying?
No, it's my glasses.
Okay. So I just really felt what you were saying, and I was going to tell you that I have a rule in my office where I don't fuss on Mondays. I only allow people to worry on Wednesdays, and we only cry on Friday. So just in case you were thinking about crying, for anybody else on the call, we got to dial it back. So, um, the first thing I want to say about what you shared is dignity. I think I've heard that word probably already 3 or 4 times this week, and it's only Tuesday. And the first thing I thought about is where are we failing in our training of future medical professionals, whether it be physicians or nurse practitioners or nurses, um, and what we need to do differently to make sure that when you seek for help or a Q&A, you can get that. And it's a safe space for you. And so I am disheartened as an OBGYN, especially that you didn't get the help to navigate that process. And so hopefully with the things that you're learning now and the connections and influence that you have, we can really work on that. But I take that to heart because I'm a professor and I really try to make sure I don't teach medicine. I teach people, my students how to take care of people, which gets forgotten. So to speak to your question, Brenda, in the medical system, I will have to just tell you the reason I became a doctor is because I had an encounter as an 8-year-old where I shared that I had a tummy ache, and the pediatrician thought I didn't want to go to school. And so that's why I had a tummy ache, and then had an emergency appendectomy and decided, kind of like you did, because I felt like I was wronged. I wanted to do what I can or could to help people not experience the same thing. So it's interesting how, your pain can either like squash you or empower you. And I'm sure that a lot of people here on the call are doing that. So I will tell you that 50% of my patients are uninsured. And so that's one of the things that I can bring to the conversation is really helping patients who don't feel seen or recognized or who can't afford to access care regularly. When they show up and they present to me, I hear a lot of that. And I hear it from patients who are insured too, where they won't listen to me or nobody listens to me. And I see that across color, size, shape, smell, all the above. And so, um, since having that traumatic experience with my appendectomy. I did have 2 children, and I forgot to mention I do have a husband too. I realized I didn't say that part just in case he's listening. But I felt cared for with my pregnancies. And it's interesting how we have all this issue with maternal mortality now, and I didn't feel scared to be pregnant. Um, that is a big feeling now where women are scared to be pregnant because they don't know what's going to happen. And it doesn't matter where you come from or what you look like, you could be in danger and you could lose your life. And so, um, but I didn't feel that way. And I think I've tried to make sure that the patients that I encounter or the friends whose friends are pregnant that I help also help get that, even if they can't get it from their own provider or their own physician, so to speak. So hopefully that addresses some of what you mentioned.
Renee, I wanted to bring you in. You said you're a MAHA supporter or a Kennedy supporter. When I say public health, doctor, mainstream medicine, kind of what goes through your mind?
Okay, unfiltered, being honest. I grew up in the era in the 60s and the 70s where the only time Black people would go to a hospital if they had a broken leg or arm. We would do home remedies because, in my opinion, I believe that, okay, the health system doesn't work for nobody. It has nothing to do with color. Nobody poor, okay, gets the help that they really need. My 83-year-old mother had urinary cancer, 2016. For a whole year, they had her, she was bleeding clots of blood in the toilet bowl. They told her it was a urinary infection. They didn't give her the proper diagnosis to go to specialists to see why this 83-year-old lady is bleeding clots of blood out. Okay, a year later, when her tumor was 6 centimeter, then they diagnosed her with urinary transitional cancer. By that time, she was not a candidate for chemo or radiation or surgery. And because of her insurance, it was hard to get her to some place like maybe Sloan Cancer Center and stuff like that. Okay, so with the certain amount of low income insurance, if it doesn't cover certain doctors or certain procedures or treatments, you're getting denied, okay, the services, and you're either left with the problem or you're left to die. So I lean more towards home remedies, and I only necessarily go to the doctor unless it's a real emergency where I have a fever or a temperature or something like that, okay, or my child or something has a temperature. Because I believe that, okay, all of this is a business. Big Pharma is a business, and they're not in the business of getting you well. They're in the business of keeping you sick, okay, because that's how they continue to make their money. Okay, and far as make America healthy again, the MAHA situation, the problem I have with that, okay, it's good and fine to want to get dye out your food. It's good and fine to want to eat healthy and, okay, have a topic about vaccines and safe vaccines and vaccine injuries and stuff like that. But when I look at a group of people and they said, make America healthy again, and I come from the ghetto, okay, born and raised in the ghetto, okay, where people are conditioned to live in rent stabilized homes and NYCHA projects for years with mold in the walls, lead, okay, rat festation, bed bugs, roaches, and stuff like that. And nobody is coming to make these people healthy again. Or you go into these underserved communities and we got expired food on the supermarket shelf, and that's the only thing that we can buy. Nobody is putting proper food and clean and healthy food in their neighborhoods. So when you want to make somebody healthy again, it should be on a whole, no matter what racket you in, whether you're rich, poor, or middle class. And that's what I have to say.
Renee, I want to ask you something and then bring Denise in. So, look, you worked for Kennedy and you were a supporter of MAHA. Are you saying that you're frustrated with the movement right now?
I'm not frustrated. Okay. I'm just feeling that they should expand their protocol when it comes to addressing making people healthy again, because it's a group of people, vulnerable population, underserved communities, that's not getting the Make America Healthy Again privilege.
Denise, I wonder if you can react to Renee. What goes through your mind when you hear, because I saw your face and I know you had lots of thoughts.
Yeah, come on with it. I mean, this is the conversation we're here to have. So I'm very blessed to be here. I think it's hard for me to know where to start because I tend to go back to go forward. So I think I'm going to do that. Um, I said that I'm a community health worker, and I said that I'm here because of my mom and my grandmom. And that means something to some folk. It doesn't mean that they pushed me to the profession. It means that they modeled a way of walking in the world and helped to cultivate an understanding of what makes health. Okay, so I think I want to start there. I am on my mom's side of the family. They are Cape Verdean. They came over in the mid 1800s on ships from Cabo Verde. Came to New England and had a very different, albeit colonialist experience, both in West Africa and in the Cape Verde Islands and in the United States. My father's side of the family, we can for sure trace our history back to Guntown, Mississippi. I have on my wall, I can go back at least until 1862, where I can actually trace the names of the people in my family. And when I think about what makes health, the reason I wanted to jump in, you must have seen that when Renee was speaking, is because one thing that is unique about being a Black woman on this call, I just can't speak for anybody else on this call, is that every one of us carries within, beyond our politics, beyond our education, beyond our income or social sort of attainment, we carry with us an awareness that we cannot escape. Whether we are on the continent of Africa or we are somewhere through the diaspora or here in the United States, that none of the systems here in the United States were designed for us in a literal sense, because we were not here. There was a time when we were not here. We did not live here. And we were brought here not of our own design. So to concretize that, when people ask me about community health workers, well, how long have community health workers existed? And what I always hated to hear was, well, in the mid 60s, a bunch of primary care docs and prevention folk, started to, partner with, and I was like, this is like somebody dropped CHW seeds, and all of a sudden we just started to crop up. So when people ask me, how old is this profession in the United States? I answer the question with a question. How do you imagine that enslaved Africans survived for 250 years of chattel slavery with no income? Let's just start there. No awareness of what herbs, what trees, what fruits, what berries, what water was safe to drink or eat or use for medicine. Who was birthing the babies? There was no health clinic down the road from the plantation. When there was a fever or a snake bite, when people were in mental distress because their children were being sold off or someone's foot was being cut off because they were disobedient or tried to escape. The question is, who made health? And the reason that is important to me and hopefully to the conversation, and it's why I resonated so much with what Renee said, because I was raised by those boomer hippies. Them black boomer hippies were raw, they were rugged, and they understood that health is about prevention. Health is about what's close to you. Health is not about, it does not begin at the point where something is wrong. Health is a function of your love and your safety and your joy and your access to clean water and food and people who care about you. What makes health is something that is far upstream from the point at which something hurts or something is in distress. Even the way that babies are birthed in the healthcare system, laying women on their backs. I mean, I don't know how far we're going to go. All over the planet, that is not how women have done it for as long as civilization has existed. So there is a weird thing about the way that women experience systems, the way that Black women experience systems. And it is not a matter of individualized racism. Now, I have experienced individualized racism in the system, and I'll just hasten it to say this. There was a rare kidney disorder that was passed down in my family. My grandfather had it. My father had it, but it never really presented. And then as I had my first child and then subsequent children, I have 4, these cysts were growing on my kidneys. They were becoming worse and worse, but it was undiagnosed for a long time. Okay. And then finally, when I had my last child, my daughter, things got so bad that I was in the emergency room like 5 to 6 times a year after I had my daughter. Okay. Like they brought a hospital bed into my home at a certain point. I couldn't work. I couldn't bend. I couldn't twist. There was nothing wrong with the function of my kidney, but these cysts were growing. And if I would bend or twist in some strange way, I would have internal bleeding. And what they said was, we can give you a lot of pain medication. And I struggled with addiction. I had such free flowing opioid. I just couldn't believe it. So I struggled with that for many years. But the issue was they said they couldn't fix it. And then I happened to find myself in New York. I was with Dr. Harold P. Freeman, who is the reason that we have patient navigation and the 2005 Patient Navigation Act. And I was taking a training in this man's class, and I had an episode and I had to go to the hospital. And fast forward, he navigated me through a system in New York, out of the state where I lived. And when I came upon a doctor, a urologist who said, I can fix this. You know what I said to him? I said, don't lie to me. That's what I said to him when he said, we can fix it. I said, don't lie to me. Don't lie to me, because for 7 years, I've been going back and forth to doctors.
Yeah.
And they have not fixed it. I have had surgeries and I have had lots of, different lab tests and so I know how to manage it. And he said, I don't know what they're doing, but I can fix it. So I've had personal experience with the healthcare system that I can sort of expound on, but that is different from health. And what Renee is talking about is the power to make health in your own life. I'm not speaking for Renee. I don't even know Renee. Okay. But this is where we need to be. Right. So when we talk downstream about pharma, when we talk downstream about, systems and the high cost of healthcare, we are already far away from what makes health. And that's why I wanted to be a part of the conversation.
I am so glad you are. If you can tell us one anecdote of your own experience with the health system that maybe led you to the MAHA movement, led you to Kennedy, is there a particular experience you had?
Well, my sister had an experience with my niece who has autism now, and we believe she was vaccine injured. So that was one thing. But just in general, I had got tired of going to the doctor, explaining to them what maybe is on my mind and what I'm thinking about, and them telling me the direction in which they think I should go without really listening to me. The last doctor I went to, well, actually, I found a functional medicine doctor that I go to now. But previous to that, I went to my regular doctor's office, and I'm like, hey, I want to get a full workup on all my different, vitamins. I want to see where I'm deficient at. And the doctor first, she looked at me like I was crazy. Like, what are you asking me? And then secondly, she was like, well, okay, that's going to cost more. And I was like, okay, that's fine. So after she sent me to get my blood work done, I got my blood work done. And when they sent me the portal thing for me to look at my results later, I noticed that no, half of the things I asked her for, they didn't even do. They just did the standard stuff that they normally check. And of course, when I inquired with her, then she's like, oh, which vitamins were you talking about? She acted like, the conversation didn't happen. And that was really the last straw for me. And I never went back to that practice. And then I was on a mission to try to find a doctor that would listen to how I want to be treated, which is to get the root cause first of what's happening to me. And then we can kind of determine what is the best treatment plan for me.
Thank you so much. I want to quickly bring Renee in because Renee, I think, had a thought on something that Denise said.
Yeah, I want to piggyback on what Denise said. Okay, but I also want y'all to understand that, okay, I worked many years in the capacity for the National Coalition for the Homeless. I was a board member, I was a co-chair for the policy committee, and I was also the co-chair for housing. I also been in many White House political strategy teams. I've been with the Federal Connection, the House Human Needs, okay, organization that operates on a federal level. Okay, I've known many people in DC, Congress, and everything. And United States of America is a corporation, and we the people, okay, are the human products. Okay, the medical field, period, started with Rockefeller. Okay, and everybody, he wanted to be put on prescription drugs and be treated through a medical field that doesn't, okay, serve us. The medical field only treats symptoms, and they will treat it until you no longer breathing. There's no cure, and there's no medical, okay, agency that ever came up with a cure. And the people that came up with cures are no longer here to speak about it. So it's a big failure in the system all across the board. It's systematic, racist by design, structural racist in the health field. And my thing is, if you're gonna make America healthy again, you got 771,000 homeless people across 50 states. Some people living in encampments. Some people don't even have health insurance. Most of them Black and brown people and Black and brown children. What are we going to put in place? What is the solution to bring something to the table to make them healthy again also, and the vulnerable population? That's where I'm at with MAHA.
Hey, Jacinia, let's hear from you on that real quick. And then Kenzie, I'm going to bring you in.
Yeah, I wanted to kind of address what Ms. Renee said. And I think that part of that in making America healthy again is, we have to take some self-responsibility. I mean, I found myself over the years reading a lot of books like Dr. Suzanne Humphrey's book, Dissolving Illusions. I mean, it's important for you to kind of know where our current health system is, what it's patterned off of, and some of the things that we've been told that maybe are not exactly correct. So I think that in order for us to get healthy again, we have to be accountable for ourselves, accountable for our families. I mean, I sometimes am out and about and I see 5-year-olds that are severely overweight. And I'm thinking like, what's going on here? But then I look at the parents and they're severely overweight, right? So that means that they're probably feeding their child the same way that they feed themselves. So we have to take some self-accountability. Because Bobby's in that office, I'm not expecting him to wave a magic wand and fix all of the issues. Some of this stuff we have to take our own accountability for.
Okay, well, I'm not blaming Bobby for anything. I also have a personal relationship with Bobby. What I am talking about specifically is the vulnerable population, people that are crawling, that cannot walk, okay, and
Oh yeah, I
need
didn't
that
think that you were. I wasn't trying to imply that.
external care. Okay, that's what I'm talking about. How do we come with a solution to make them healthy again?
Thank you, Renee and Jacinia. I want to bring Kenzie in, and then I also want to go to Dr. Keisha. Go, Kenzie.
Yes, so let's talk about the issue of being in so much pain and not being able to stand up. And Denise, I want to lift up the fact that you outlined your lineage before you shared your story and your insights, because those are the people who are on our shoulders now, who were vessels for it, because they never had these platforms. So for me, my dad's lineage is from a city called Greenwood, Mississippi. It's named after my French ancestor named Greenwood LaFleur. So I'm a direct descendant of him. And my grandmother, she grew up in Bowling Green, Kentucky. She was born in 1931. In 1937, she fell into what I'm told, at least according to family lore, is a snake pit. She broke her arm. And when they went into town, I forget what the nearest city was, and they asked if someone could reset her arm. African American, they said, go to the vet, go to the horse doctor across the street. We're not going to treat you here. And so the horse doctor goes, resets her arm the same way they would reset a horse's arm. And my grandmother's left arm, she passed away at 92. So that's 86 years. It never fully functioned because she was treated like an animal. And I have a lot of different instances across my family line, even it taking me 8 years to receive a diagnosis of polycystic ovary syndrome, um, being told that I don't have it when I was 18. Then when I came back 2 years later, after having gained about 45 pounds, telling me it was an issue with my weight, I needed to lose weight, even though I came to them 2 years prior being underweight. And so that's just to say, when I hear this refrain, make America healthy again, I wonder where that again comes from when this system was A, built on Black people and Black women's backs, and B, it is diseased by design. In order to make something healthy again, it had to be healthy in the first place. So Brenda, were you going to say something?
Well, I wanted to see if one of our MAHA supporters maybe could weigh in on that. Why don't we start with Jacinia? What do you think about, the what Kenzie's saying, make America healthy again? Where are we going back to?
Well, I mean, I think that I would prefer that we don't use umbrellas to think that a particular movement is going to address everything that's happened in the past. I think MAHA is specifically addressing more, let's say, for example, the fact that, 70% of our children are not fit to join the military, right? There was a time when we all played outside, we all ate better than we did. And I think that's the general umbrella that we're talking about when we're talking about MAHA. We're talking about the overall health of this country and what it was at one time. There are systematic things and racism, of course, all those things transpired as well. However, we didn't have such an increase in obesity, for example, even during all those things that were happening. So I think MAHA can address some things. It's not built to address everything when it comes to health and its, inadequacies.
Can I just ask you, Cindy, some folks here have sort of outlined the history as sort of a community that has to take care of itself, that the system's not going to be there for you. Someone in the community's got to help you deliver your baby. Someone in your community's got to help you, come back from an injury or seek, herbal treatments, going back as far as that. You don't see it that way. You talked about again as being a time where people ate differently, got outside. Do you see that disconnect though? Could you see how some people are thinking, go back to what? Go back to where we were ignored by a system. The doctor wouldn't see us. They sent us to a vet. Like, can you see that tension that sort of again is sort of speaking to everybody here?
Yes, I do. And I think that's why I said you have to separate that, because I think everything that they've talked about is real. It's happened in our community and continues to happen in our communities when you talk about, higher death rates and and childbearing and all those things like that. So I don't disagree that those things are happening. And I do think that we have to take more control of our health because we know of those inadequacies when it comes to people of color. I'm just saying that in this particular movement, it's not going to address, no movement is going to address everything, in every situation. And that's why you might have subsets of people in those movements that would say, hey, okay, I get all this. That's great. We need to eat better. We need to be in better weight. We need to go outside. But I also see that Black women are dying at higher rates during childbirth. And so that's an area I think I would like to focus on, or find my tribe, or make sure this particular thing gets addressed.
Renee, do you agree with what Jasinia's characterization is of MAHA in that way?
Okay, Jacinia, okay, I understand that no one movement is going to solve the problem. And I actually knows the executive director of MAHA. We're happy to be friends, me and Cooper Deal. Okay, but the reason why the subject is coming up and the pressure is now being put on MAHA for the simple fact is that it's not only MAHA that is saying make America healthy again and addressing certain things. MAHA is being used in MAGA, okay, to make America healthy again. So it done took on a whole different tone.
Yeah.
I'm sorry, that last, you said it's being used where else?
Mega. Okay,
MAGA.
Okay, I get what you're saying.
That crew, okay, that crowd.
Well, what's your, I mean, you're saying that because that doesn't make you happy, it sounds.
No, I'm saying, okay, I'm a person that addresses the root causes of issues. And I use a lot of wraparound services to push people towards self-sufficiency so that they have options. So, okay, sometimes, okay, people join movements, okay, for whatever reason, okay, there's a lot of lip service, no solution, lip service, no action. And I'm an action person. So if I see a group of people and they're addressing this and it's constantly a big movement behind it, okay, but then I turn around and I look at the other side and these people are still in the same spot, suffering, and nobody is coming up with, okay, solutions or ideas to at least explore and address what they're going through. I have to ask the question, okay?
I mean, I understand that, but I just feel again that, MAHA cannot solve every problem. Bobby Kennedy is one person. And I also think that then that takes away the responsibility on maybe our local representatives and the people that we do see more on a regular basis, and having them address some of the medical issues that we have in our communities.
I understand Bobby cannot do everything by himself, okay? And it plays a big part, okay, on both.
But I hear people in the MAHA movement doing that, trying to well, why hasn't he done this? Why hasn't he done that? When is he going to do this? And that's not addressing the bureaucracy that he has to deal with. That's not addressing the fact that he has to finesse some of these situations, or that he's just one person and only so many things can be put on his plate. And
let me jump in, because let me tell you something, Renee and Jacinia, having the two MAHA supporters engage in debate was not something I was predicting on this call, and it's really interesting. And it actually gives us
the Republican and the Democrats alike, Congress, okay, the House, the Senate, the local state assembly, the city council, the Senate, okay, everybody, including the president, plays a part, okay, in making, okay, America healthy again and making America great again, okay. But so far, the reason why no problems has been solved because it's the Republican blaming, okay, the Democrats. The Democrats are blaming the Republican. They all are part of the same corporation corrupt machine. And to me, Bobby's in the middle of it, trying to do what he can do in the White House to make something happen, okay, for the people.
Speaking of for the people, I think one of the reasons why we wanted to convene this group of people was to really focus on health and how we got to where we are. And we heard so many stories just in the past few minutes about, they didn't say it by name, but, this kidney disease. And Dr. Keisha, I have a question for you, because as somebody who's been in the communities and taking care of patients who, do feel that the healthcare system has turned their back on them, when you hear this frustration, when you hear the exasperation, what comes up for you, as a physician? How should the physicians, the providers, the healthcare, the medical community, I'm not even really talking about the public health community, the medical community respond to what you're hearing? Because this is what people are feeling, but we need some sort of perspective about what it's like to actually be on the ground with this. Dr. Keisha.
Thank you, Dr. Mark. I actually have a broken heart right now, listening to a lot of the experience that have been shared today. As someone that's been practicing, like I said, for almost 20 years, it's heartbreaking. So I'm going to pause for a second and just talk a little bit about federally qualified health centers, which, by the way, when um, Mr. Kennedy addressed there's a meeting in DC last week for primary health care, and my CEO for our federally qualified health center attended, and he talked about the importance of federally qualified health centers. And I'm hoping everyone is familiar with how that structure works because we take care of everyone. And I did mention that probably half my patients are uninsured, but we take care of the uninsured, and then we take care of patients that have private insurance. And so having said all of that, it is very unfortunate that patients and people in our community do not feel seen or heard or taken care of. Because the whole idea of medicine is to take care of people and to what was mentioned before, not just symptoms, not just, take this for your headache, but why does your head hurt? And so I do have to share, um, and I know I'm not the only one practicing in rural underserved communities where we are here to really address what's going on with our patients. And so unfortunately, Renee, which my middle name is also Renee, and I did spend a year of high school in New York in Canarsie, so I do have some connection. And I'm originally from Jamaica, so we can talk about that in a minute about what, immigration looks like and how we integrate. But when I have a patient that comes in to see me, I do not write a prescription for my patient without asking them, can they afford it? And when can they pick it up? Because they might be getting paid on Friday. And so they say, yeah, I'll get it. But if they have a UTI on Monday and they don't get paid till Thursday, then I need to send the prescription to Walmart so they can get it for free from the list. Okay, so that's an example of what the practice style looks like or should look like, not just in my rural community, but everywhere. And so that's the first thing. The second thing is I've had patients who have come to me because they may ride the transportation van and they need a medication, but the van won't take them to the pharmacy. And so I'll say, well, wait here. I'm in a rural community, so I can get away with this. And I can run to the pharmacy, pick up the medicine, and come back, give it to them so they can get on their van to go home. So I think it is very unnerving for me to hear the stories, but I need to hear because that helps me in my teaching. I teach medical students, I teach residents, I teach nurse practitioner students, I teach physician assistant students. I mean, I cross the gamut. And so everything that I'm hearing, in addition to my lived experiences with the challenges that my patients face, is an opportunity for me to infuse that in my conversation with my colleagues who hopefully are going to be teaching, but also in my students who are going to be the future practitioners. And so this is a difficult conversation, but it needs to happen. And I will tell you the one word that I kept writing on my notepad is self-advocacy. And I've told people all the time, if you go to the doctor and they don't give you the right answer, you got to find another one. And sometimes you got to go to a different state to do that. I have patients driving 2 hours to come find me so that I can listen to them, which is absurd, but it does happen. And so I think the federally qualified health center network is unique because your quality of care is not impacted by your ability to pay or any changes. So I had a patient this week who came in and she said she had an Explanon for her birth control. It was expired 2 years ago. And she said, well, I lost my insurance. And she said, I didn't know that I could come because you have a program that allows us to provide birth control. And so I am very intentional when I see a patient. Do you have insurance? Okay, if you lose it, you can still come. If you don't have insurance and then you do get it, you can still come. So that continuity of care, I realize, is not something that everyone is aware of that we can offer through the federally qualified health center system, or that patients realize. Some people only come to us because they're uninsured and they think like we're the bottom of the barrel, so they're only here because that's what we can do. But I think that the care that I can provide and do provide is very reasonable. And so
Are
it's
there enough
hard
of
for me.
you? Are there enough of you?
I don't
No.
know. Well, I mean, Brenda, can we talk about our story like for a quick
Yes.
second?
Yes.
So I think it's about the practice philosophy. And so every time I meet a woman, I'm thinking about her health, which is crazy because sometimes I can be really nosy. Like with Brenda, we met and then I was like, "Have you had your mammogram?" And she was like, "No." And I was like, "What are you talking about?" And when I tell you that I don't know, I did not know her, but I harassed her every single Wednesday until she got her mammogram. So what I want is for us as a community, and I love community health workers because when I talk about advocacy, just like doulas are that advocate in the room when there's a delivery and they don't know the physician or the midwife that's taking care of them. But that advocacy is really a collective and a community responsibility. And what's happened is, 20 years ago when I was growing up, I'm older than 20. So it's in the summer, I would go to my aunt's house and she would comb my hair and I would eat there because my mom was working. We don't have that community anymore because we are so diverse in where we live and our positions and things that have happened. And so you're right. We do have to get back to where we supported each other in a different way and not just depending on one particular source for that to happen. But I also, last point, health, you're absolutely correct. It is not just about absence of disease. It's about well-being. It's about feeling good about what's going on with yourself. And we're all on that journey and have personal stories for that. But your healthcare provider should be a part of that care committee. I had a patient yesterday and she lost weight. She's young. I looked at her arm and I said, "Why does your arm look like a grandma arm?" Not in a rude way, but literally like I can tell something's going on with her stomach. I said, "You need to eat more protein." She said, "I don't have an appetite." I said, "I'm going to check your labs and we're going to come back." And she said, "I'm so glad you looked at my arm." And I thought, that's what I'm supposed to do, right? Like, I scan my ladies. I look at the hairlines. I look at the toes. I look at the toenails. I look at the teeth. When was the last time you went to a dentist? So all of our doctors should really be doing that. And it is unfortunate that that's not happening. So separate from the system, our training, we have a lot of making up to do. And so I'll pause there.
Jacinia, I want you to jump in and just say what you just wrote in the chat. Jacinia, MAHA supporter.
I just said that, and Dr. Collins, you are the type of doctor, and that's the experience that I want to have when I go into the doctor's office. I love that you are paying attention to your clients. That's what I want. I want somebody who's going to care for me, who's going to look at me and point out some things that maybe I don't see. And then, we're going to work together to figure out what's going on and how to fix it. So thank you. Thank you for being that kind of doctor.
And if I could just address, I saw the comment about funding. So actually, we got additional funding last week. And so there's some things that are changing that are helping us to be able to do the work that we're doing. And let me just add, I'm
Keisha,
OB. Oh, yes.
I
Can
don't
you hear
mean
me?
to interrupt, but
Oh, go ahead.
so our listeners can't see the question, so I don't
Oh,
know.
perfect.
Well,
Yeah,
Okay.
if you
let's
I'll
want.
let's
just,
let's wait on that for 1 second, Keisha. I
okay.
want to bring Kenzie, will you steer a little bit and then yeah?
I actually want to speak to the very last insight that Jacinia shared that Dr. Keisha, you should be the standard and not the exception. And Alexandra, I know that you are in the policy trenches right now by trade in your day-to-day job. And something that I wanted to ask you just very simply, and I appreciate you all's grace in advance because this is very much a leading question. I'm not a journalist, but what can policy do to train up and also sustainably financially back doctors like Dr. Keisha? So what would it look like from a policy perspective to bring in a public health and a clinical workforce that is more made in the image of us? And as you think on that question, I wanted to share too. So currently, I live in the UK, and I shared earlier that it took me 8 years to receive a PCOS diagnosis. I received it just a couple months before my 26th birthday last year. And so I was thrown onto Medicaid shortly after getting that diagnosis, got off of my dad's employee-sponsored health insurance, and that's a complication in and of itself. And that timing is something I'm still trying to emotionally and spiritually navigate. But what actually sparked my diagnosis is when I was doubled over in my bed in the UK, and I nearly crawled over to my college nurse. And she gave me a urine test. But before she did, she said, "Love, I think something's going on with your ovaries." And so that's just to say, in defense of public health and defense of medicine, it's not medicine fundamentally, from my point of view, that needs to be rejected. It's the fact that America is built on a system where who can practice medicine and who can receive medicine is based on a hierarchy. And it is considered a privilege rather than a right. Because if I was able to get a near immediate diagnosis in the UK, and maybe if I was in Twix County and Dr. Keisha was my OB-GYN, maybe I would have gotten that diagnosis. I think that it is a fundamental problem with who dominates the narrative and the practice of medicine currently. So I wanted to share that, and then Alexandra, go to you for the policy lens.
Yeah, absolutely. And I'll answer your question kind of like in two pieces. So like the first part, I think from a policy perspective, it's really hard. And I think some med schools and hospitals have tried to kind of integrate public health into like traditional medical education. It's hard to require it. Some doctors I know opt into it, doing like a dual degree, some classes. It's really hard to have that requirement and force, physicians to take those classes. The same way it's hard for them to do nutrition classes, which are fundamental to health and well-being. You would think that that's part of the medical school education and that should all be encompassing in one. So it's hard to kind of make that a requirement for all medical schools to have this public health lens and have a more social determinants of health perspective for doctors. I think it should be a requirement. I think, if you're going to be treating patients, you should have that perspective that looks at the whole being and the whole body and the policy, epidemiology, all the perspectives that affect each individual person, especially as we look at different disparities that affect different groups too. Specifically, as you look at maternal mortality and everything else that's going on in specific states. Went to school in DC, so that was a big topic of conversation consistently throughout the public health school as well. So like most of the doctors from GW were trained to look at, specific data points throughout the DMV area. So that, I mean, they learned that there because the physicians and the doctors were trained to teach that as well. That's not the case everywhere. Um, so it's hard to kind of enact that policy, especially right now as like public health's being cut, social determinants of health aren't really being focused on the federal level. So it's kind of disparaging, but I think you have people on the ground who are doing the work and are constantly pushing that forward, and will consistently be talking and advocating about it in despite of the federal cuts and despite of what's being scaled back, that I do feel a little bit better and kind of encouraged by it. But it's hard to kind of have a federally mandated requirement for that. So yeah, it's a little bit like a catch-22 thing. Yeah.
Thank you, Alexandra. Renee, I am going to come to you, but I want to actually bring in our two CHWs on the call for a second because there's something, and ironically, they both had their hands up, so that works out. But here's my question for you. We are living in a moment where obviously there's a lot of just very strong emotion about how this current administration is responding, and you had Alexandra talk about cuts and things like that. But my question is, if you imagine the time before the administration came in, this is specifically to Tribeca and Denise, who've worked in the community health worker space and are continuing to do that. Do you feel that the public health sort of establishment recognized your work? Do you feel that you were given a seat at the table, that your work was amplified, that you were part of the decision-making class that is involved in, how interventions are created and done with the community? I want to go to Tribeca first and then Denise.
Yeah, absolutely. To be to Alexandra's point, I feel like public health is being more integrated into the healthcare field. Before, I feel like it was on a need, an emergency or a last minute kind of need type of basis, in a sense that they didn't have any other option. Let's bring in a CHW, or it wasn't like the first thought to have a community health worker or any type of public health aspect integrated. Now, just an example of how public health has been integrated in to the field. I am currently a part of a mentorship program where CHWs are mentoring C-suite executives. And we've met about four or five or so times, and we kind of get into the uncomfortables, talk a lot about bias and racism, and how a lot of these policies came about, and how our patients get the short end of the stick on a regular basis. So much so that last week, one of the doctors mentioned that a training class that came in, there was a situation where a parent, I can't really remember what happened in a sense, but it was something. Oh, vaccines. Sorry, they didn't want their child to get vaccines. The response of the medical student was, what should I call CPS? They don't want their child to get, vaccines. Am I reaching out to CPS? What are the next steps from here? And this is essential to why we need CHWs in these frontline rooms, training and hitting the ground, letting people know how they should be approaching people moving forward if we're going to, see any change. So.
Wow, I had such a reaction to you saying that story. Denise, what went through your head, and what do you think about the inclusion of community partnerships in these community-led partnerships in kind of academic public health, big public health from the previous era?
Yeah. Well, I think it actually ties into the comments that were sort of woven together from Dr. Keisha and Alexandra, and with respect. I just want to say again, perhaps I have not said it emphatically enough. I appreciate every MD who desires to go deeper in their public health awareness or theory. I appreciate all the exploration into the social determinants, although I want to say with love, it's kind of funny to me that we have to name this thing called the social determinants of health or social drivers. This is food. This is water. This is a place to live, right? This is heat when it's cold. This is, a cool, air when it's hot. This is safe streets. These are these things. And so sometimes we theorize our way and we spend time making a perfect theory and not actually doing the work. Okay. But what I want to say as a community health worker, I actually don't need more doctors with public health training. Okay, with respect. What I need is better investment upstream before I get to a doctor. That's what I need. I want the doctor to do what the doctor does. I'm not a doctor. Respect to all of that training. And I'm looking for you to implement all that training when I show up. But before I show up, I should have the literacy. I should have the access. I should have the opportunity to both access directly if that service exists, and I should advocate if it does not exist and make demands upon my tax dollars first and foremost. because the amount of what we're talking about that is funded by tax dollars does not align with what we know about what impacts health. Okay, so I'm not saying anything that folks don't know. We have generational poor health. So let me just make a quick statement about this is not about an administration. I don't care who's in office. I don't care. I'm just telling you, the systems were not designed for us. You are not going to change the system by just putting a different person in office. And so this is a straw man to me. We as community health workers advocated. I don't care who was sitting in the governor's seat. I don't care who the head of the medical school was, and I don't care who the president was. There have always been we have generational poor health. We have tens of millions of people in a pre-diabetic state.
So you've been doing you all this time. You've been doing you.
Sorry.
And you've been doing you all this time before MAHA came, before the Biden administration came.
Listen, if we had time, I would talk about the promotoras. I would talk about the community health representatives on tribes who show up to work every day and then they go home. 96% of them on Navajo Nation with no electricity and no running water. These are women hitting the ground. You understand what I'm saying? These are women who have grown up in Hmong communities. They were 6 or 7 years old translating for their grandmothers because didn't nobody speak the language. Women have been doing this work from time. All kinds of women. Okay? I worked with white women in Connecticut who thought they didn't have to take prenatal vitamins because they thought their income level meant that they were getting all of their nutrition. We got many problems here. Okay, so this is not about isolating it, but the issue financially is we need to move upstream. Okay, we know that 80% of what impacts a person's health should not or does not require a medical treatment, a prescription, a doctor. Okay, but the investment is not even in the primary care or the family doctor. The investment is in the specialty. So once again, our dollars are not going where we know it makes health. You want to fix that bodega?
Yeah.
You want to fix that bodega, or do you want that person ending up in the emergency room?
Let me just ask, just picking up your phrase, which was so well put, our dollars are not going where we need them to go to improve health. And Renee, I just want to ask you, one of the hallmarks of this administration has been to end health research, scientific research that examines these issues through the lens of DEI, diversity, equity, inclusion. Do you think that that was a good idea to end that sort of research? Or do you feel that that research is needed, has a place in this conversation, should not have been cut?
You asking me that question?
Yeah.
Tom?
Yeah, to you, Renee.
I think that it shouldn't have been cut. I think a lot of programs shouldn't have been cut. Okay, because, like Denise said, okay, we have generation of condition through the bloodline of people with failed, health decisions on mostly the poor. Like, I'm going to use an example. When the COVID virus hit, a lot of people didn't feel right with taking this COVID shot, but they were mandated and forced to take it. And they had to choose between being able to pay their rent or being homeless, being able to put food on the table to feed their kids, or be without because they didn't take this shot, And then they will sign papers that if they have any type of injury, that they could not sue, And now, even down the line, there's coming all type of vaccine injuries. And I'm not saying that Bobby's not in the office and he's not doing what he needs to do, as far as the human health services, but you have to look at the whole picture, of the government. There's been a lot of gaslighting. There's been a lot of bureaucratic BS. There've been a lot of inside trade deals, kickbacks, okay, backroom doors, deals made that we didn't vote for, including health. And I done been in situations where, okay, doctors, okay, were locked up for corruption or Medicaid scan and medicine scan and all types of stuff like that.
Yeah.
And what I'm trying to say is that, okay, I represent the most vulnerable population, okay, people that are at the bottom trying to find some type of space out of life to push themselves towards self-sufficiency. Okay, you're talking about health. Okay, Flint, Michigan still got brown water. They still drinking dirty water. Why? Okay, this shelter that I'm getting ready to protest March 21st in Brooklyn. Okay, it's a family shelter. They're living with rat infestation, bed bugs, roaches, brown water, moldy food. Okay, so these are people that are families with children that are crawling, trying to walk. So
Yeah,
how do we
Renee.
come up with solutions to help them?
Yeah, I think
help.
there's no shortage of problems. That's for sure.
Okay, so that's all
I
I'm trying to say. I'm not, saying a person is not doing something they're not supposed to be doing, okay, or doing something they should be doing. Okay, to me, the whole system needs to be torn down and rebuilt. Okay,
Well,
these places need to be revamped.
let's
Okay,
talk about Renee. Let me just get in here for a second, because I think you know the passion that you have is definitely felt, and I think one of the things that is definitely happening and we're definitely seeing is this sort of reduction in DEI funding, elimination of programs. Like, when you hear that diversity, equity, inclusion phrase, is it a political phrase to you? Is can you have DEI that is, consistent with excellence in science? You've heard about Denise was talking about how we need to have people come to the doctor's office with literacy, with information. Do you think, like, for example, the DEI programs that are funding, school lunches and funding lots of programs and after school care programs in school, that those have just been lost in 11 states? Is all of that sitting well with you, with your desire to make these changes that you're calling for? When you hear the DEI cuts?
No, it's not sitting right with me, for the simple fact is that, okay, cutting HIV programs, cutting Medicaid, cutting SNAP, cutting Section 8, all these programs are some people lifeline to keep them motivated and keep them inspired to move forward in life. And if they're cut off, okay, some of them are lost and they have no way of where to go next.
Yeah. Alexandra, do you have some thoughts about, the DEI narrative that we're hearing? I mean, do you think that this narrative is consistent with excellence in science? Is it moving in the right direction to restore integrity in science by eliminating DEI programs?
No. I think, I mean, to put it honestly, Renee, like I think when you cut off programs that people rely on a daily basis, like the baseline, like I think about kind of like some of the work that I was doing towards the end of the year when people were trying to figure out insurance and what was going to happen with premiums and stuff. When you start to take away and incite fear of what people are going to do and how they're going to afford their basic necessities, and then everything else is in free fall, that doesn't help anyone. That doesn't help. That doesn't inspire or make people strive to do better, as like I think that's the justification they use, so people don't rely on the government, whatever it is. That doesn't help anyone. So no, I don't think that's the right direction whatsoever. And Renee, I'm in complete alignment with you on that. That's just it's horrendous. Yeah.
I know we have some hands up. I actually want to play a soundbite from Secretary Kennedy's confirmation hearing. It was on January 30th. And I want to get a reaction. And I want to first get Renee's reaction and then bring some other folks in. So I'm going to play it. Now, this is going to take me just a minute because I have to unplug something to make it play. So just give me a second. Thank you. This is Senator Angela Also Brooks from the great state of Maryland, who is questioning then nominee who became Secretary Kennedy.
You said you were on a show on February 26, 2021, an interview with Dr. Judy Mikovits, where you said the following, and I quote, "We should not be giving Black people the same vaccine schedule that's given to whites because their immune system is better than ours." Can you please explain what you meant?
There's a series of studies, I think most of them by Poland, that show that to particular antigens that Blacks have a much stronger reaction. There's differences in reaction to different products by different races.
So I have 17 seconds left. Let me just ask you then. So what different vaccine schedule would you say I should have received? What different vaccine schedule should I have received?
I mean, the Poland article suggests that Blacks need fewer antigens than.
This is so dangerous.
You get the same measles vaccine.
Mr. Kennedy, with all due respect, that is so dangerous. Your voice would be a voice that parents would listen to. That is so dangerous. I will be voting against your nomination because your views are dangerous to our state and to our country.
I mean, do you think science is dangerous, Senator?
Okay, so let's go to Renee, who's a MAHA supporter. Kennedy worked for the Kennedy campaign. Renee, what's your reaction to that?
My reaction to the whole thing is that, okay, Kennedy is not a doctor, okay? He's not a licensed doctor. He's not a primary. He's not a specialist, okay? And he's probably, he said he read this and he researched it. So when you research and you read something, okay, you get information from different channels, and maybe the information he got was inaccurate, okay, to what he was, describing in his hearing. But, if you're not a prescribed doctor, how would you know if all of this is accurate? Okay, I do research too, and I get, articles and information and stuff like that. And, people are explaining their agenda of how something is supposed to go or what's the solution to it. But if it's not known facts, it's just somebody's opinion.
Do you think that the MAHA movement and Secretary Kennedy see and understand the health of Black Americans?
No, I don't. That I don't. Okay, because it's too many things happening in the Black and brown community. Okay, maternity deaths. Okay, going into the emergency room and coming up dead. I had my own experience in my personal family. My older sister went to the emergency room, and the emergency room let her sit there and go into a diabetic coma. Then I had an experience where my child had to be rushed to the hospital, and she was admitted, and her face was swelled up with hives and stuff like that. And they said, oh, her blood pressure was up to 190 or something like that. Okay, so I happen to have people that work in the medical field, and they said, they're saying your daughter blood pressure is this, and her heart is rate went up high, and they need to give her medication in the through the IV, and her eyes are still open. I said, yeah, her eyes are still open, and she's can talk and see me. Come to find out, the equipment that they were using was outdated, okay, and malfunctioning. So they had to go in and do it manually. When they went and did it manually, the blood pressure and the heart was at a normal rate. So you were getting ready to inject IV medication in my child, okay, under false pretense that that's what, okay, your machines were saying. It's her blood pressure and her heart rate. So, It's a lot of, inconsistency around the medical field, the hospitals, the doctors, and it's a lot of misinformation, okay, being spread outside, okay, and into political, okay, elections. So, I mean, it's a whole massive system failure all across the board, okay? I don't see no other way of coming back from this, okay, because the rabbit hole is so deep, is you have to tear down this system and build an alternative, okay, to where people, okay, can start treating people like human beings. People can start doing their jobs. People health can get better no matter what color they are, no matter how rich, poor, okay, they are, that people will just be treated like human beings and show some compassion and empathy. And we don't have this in the world.
Okay, Renee, I find this so interesting. And Dr. Callens, I would love to fold you in here. One observation that I had, and please, please, please keep me honest if I'm wrong, is the reaction to what Bobby said is that he's a doctor. How could he not know that? In the same breath, though, so much of MAHA, just from my personal interactions, has been disparaging doctors. And so there seems to be a little bit of a contradiction between saying, like, do your own research, don't listen to the experts. But then when someone comes on whose voice could influence people's health behaviors and outcomes, even beyond this administration, and it's dangerously inaccurate, it's saying, well, he's not a researcher, he's not an expert. What can we expect? And I can't help but on a conversation with Black women, thinking about how often society at large gives white men that sort of grace. Um, and and so I want to take a moment to sit with that and also bring in um, a doctor's perspective as well. And I will say, Dr. Callens, that should you happen to bring up vaccines, a quick note on vaccine injuries for me too. I'm always listen. My grandparents are my people. Like my one tattoo is of my grandparents. Um, all three of them who I knew growing up got vaccines whenever they could. And it's because when they were younger and they saw their classmates debilitated for the rest of their lives from polio, when they saw, like when they had that institutional memory of the Tuskegee syphilis trials where penicillin was withheld even in the middle of the trials when penicillin existed, they know that's also ancestral knowledge, that memory of what happens when more traditional medicine is withheld from you. And them knowing, not always having access to that, how much the benefits can outweigh the costs, they decided to get it in their older age when they could. All my grandparents are not everybody's grandparents. And I think that the ability to make informed choices is still something that needs to be very importantly factored into this conversation. And I want to honor that point of view. But I just wanted to share a few, I'll call them I'll call them heartaches or pain points that are coming up from me. But I also want to defer to other lived expertise, including yours, Renee, and including Dr. Callens, who I'd like to hear from next.
So my reaction, I had to close my eyes actually, listening to that. And the term that came to mind is just medical injustice. And I immediately went back to, you all are probably familiar with Dr. Marion Sims and the father of gynecology and how that construct has been dismantled because we now understand that there were lots of things that were done to women because it was thought that they did not feel pain or they would not be injured or harmed or scarred in any way, and nothing could be further from the truth. And so kind of had a flashback GYN moment there listening to that. And it's really unfortunate because what we have is the human race. What we have are people. And what we're lacking is really empathy. When it comes to that research and that statement, there are some considerations that need to be made based on people's cultural experiences, but not to be used in a way to withhold access to treatments that could be helpful. For example, I've been doing a lot of reading lately about how different cultures embrace childbirth and looking at what the Chinese culture will do, or maybe a Syrian culture, and just looking at how they embrace things. And so it is important to understand people so that when you give advice and recommendations, you are honoring their history. And when I think about differences, I think about learning them so that I can tailor my care in a way that will be reasonable to the person that I don't look like. And I take care of people who don't look like me all the time. And so it's really unfortunate that that mindset, which is usually unfounded in research, is still propagated. And so our responsibility now is, I did research recruiting after I finished my public health degree, and I went through the entire state of Alabama. It was the PLCO trial looking at prostate, lung, colorectal, ovarian cancer. And my task as the director of that initiative was to recruit 1,000 African Americans to participate in a research study. Now that is seemingly impossible. It wasn't. We conquered it with our team. I went to Tuskegee and was able to recruit participants to participate, not to participate, but to engage in the research, because what we were offering were screening tests, for example, colonoscopies, to help in the detection of colon cancer, which we now has recently, we've lowered the screening rate from age 50 to age 45. And so I'm sharing that because we do have a lot of scars from our history. But as a community and as a human race, we have a responsibility to embrace those things, but also still help everyone continue to move forward and do everything we can to make sure those injustices do not continue to happen. And they do. I know it happens all the time because I hear it. I went in and they did this, and I'm like, what? They didn't tell you what? And they took your ovaries out and they didn't do this. And so I hear that all the time. So we still have a lot of work to do. But my last point is I wanted to address something that Renee said about the COVID vaccine. And I use this term all the time, don't let a good crisis go to waste. So let me tell you what I think about the system that happened, or the response of our system during that time. We had a huge outreach to vaccinate people. What I would have liked is for every time there's an encounter to put a shot in the arm, the question was, do you have a provider? And if you don't, how can we get you to one? We wasted that infrastructure. If we touched that many people by trying to recruit them to get vaccines, that would have been a great contact point to reestablish care. And a lot of people who succumbed to that disease were patients who are people who had underlying medical conditions, who were not under care. And so giving a singular, seemingly panacea for one thing without taking advantage of the opportunity to connect with that patient is a loss. It's a public health loss, it's a medical loss. So when I see a woman or someone comes in for a mammogram, I'm asking about colon cancer screening. I'm asking about family history. I mean, I don't waste, if you call me, you tell me your nose is running, I am going to ask you when you had your last pap smear. And so I think that as a society and as a system, we are still symptom-based and singular-based, and we're not using our interactions in an opportunity. I had a patient the other day who had a baby and preterm, had anomalies, had surgeries, and she saw another practitioner, and she said, nobody asked me how I was feeling. How can we see people, take care of them, and not ask about their mental state? So we are still, I was going to say deficient, but I'm going to be positive. We have room for improvement in how we take care of people in our community. And that's my thing, is we're focused on these little things, but we're not increasing access to care, access to quality care, access to coordinated care. If I have a patient that has a problem and I cannot solve it, I have to get on the phone and find somebody who knows it. And I'm GYN. So if you have a belly button problem, which I don't do belly buttons, so I'm going to find the belly button person, right? Like that's how the community, the care committee is supposed to work. And that's where we're deficient. And that is where we need to help our monies go, to helping that coordination of care. And it shouldn't depend on your insurance. I mean, it just shouldn't, or lack of, for that matter.
Yeah,
So,
I think just a final note on that soundbite, because I think it was very powerful, and a lot of people, it's sticking with them. I think, a big goal is to eliminate the misuse of race and how we take care of patients. And if we're talking about how do you, if you believe, and there could be biological differences in how we all respond to vaccines, which is why there's sometimes 2 doses or 3 doses. And we don't fully understand all of them, but there's nothing in the research that shows that we need to have a different schedule based on race, just to be clear. But if we are interested in that question, then, what we do need to focus on is making sure, like Dr. Keisha just said, that we have equitable representation in the clinical trials that are going to set the recommendations. And a lot of the DEI cuts that we're hearing about is taking that off the table. If you can't recruit people based on, diversity and race and all this, representative of the population, then you will never get the answer to that question that, Secretary Kennedy said he was seeking. One thing I do want to turn to a little bit, if I can, is this idea of lived experience, because I think we've all talked about it so much. And I think we all feel that that is really powerful. And I've heard a phrase here at least 3 times. I'm trying to keep a little count, that the lived experience is the new expertise. And I think we've had an honest conversation, and I want to keep it that way. If we look in the mirror, can you really have an honest conversation about lived experience being the new expertise if, like, other people have different lived experience? What if it contradicts ours? Like, whose lived experience is expertise? Do we need something beyond lived experience? Like, I just want to make sure we understand that. How do you be honest to your lived experience, but still be honest to scientific pursuit, facts, recognizing bias? I don't know who might want to take this. I think Tribeca, I think you did use the phrase lived experience. Tell me how you feel about lived experience and how that fits with expertise in science.
Yeah, absolutely. I honestly believe, for me personally, lived experience is the reason why I'm in this room. I personally don't come from, I guess, a background of education, resources, or privilege. None of those things existed in my world. The only thing I knew was what I was taught. That wasn't always a good thing, but I used that to help me grow rather than become a crutch. I will say that lived experience, being the new expertise, is essential when it's understood that there needs to be a transfer of power. Not your average lived experience from your typical doctor or educator of health or mental health, public health, physical health. I feel like understanding that there has to be a transfer of power. And those who aren't typically in the rooms, those who don't typically have an opinion that matters, honing in on what they have to say, using that to drive better outcomes.
What's interesting is we often talk to MAHA folks, supporters of the MAHA movement, and they come to this lived experience versus expertise subject perhaps differently than this crew does. They often have the access to health and the healthcare system, but they don't trust it, and they feel like they need to rely on their lived experience more and have that be part of the conversation rather than just this top-down, this is what the science says, what the data says. But it sounds like from this group, you're coming to lived experience as an essential ingredient because that's all this community had. It didn't have the access to the health systems. So it was part of the way that you cared for one another. I'm just wondering if anyone can reflect on that. Sort of, you're coming at it from a place of not being part of the system, whereas often when we hear this topic of lived experience, it comes from people who have had access to some of the best medicine in the country, but feel like they need to defend lived experience because the system's getting it wrong.
Denise,
yeah.
Wait. Denise, can you jump in with that?
I would like to, because I'm cautious here, and Tom, hey, it's good to meet you. I'm cautious here about making some sweeping statements. Okay, so I just want to, like you all are coming to this as, so I'm a little cautious here, particularly when we talk about Black folk and science. Okay, because when I think of Black folk and science, I think of Egypt. You understand what I'm saying? So I know, yeah, I have a sense of the history of scientific rigor among people of African descent for centuries. Okay, so this is not like our lived experience here in the United States is sort of as enslaved peoples, those who had that experience, because all people, Black folk here in the United States, don't have that experience. So I just want to be careful that we're not, just like painting a big brush. Because when I think about vaccination, I think about Osinis in 1721 and his enslaver, Cotton Mather, learning from him and the Akan tradition of inoculation, of taking the pus and actually rubbing it into a raw wound. And Cotton Mather took that technology and gave it to someone else who developed vaccines, what we now know as inoculation. So the fact that a lot of Black folk don't know that just means that I had access to a book and I could read about it. That's not my lived experience, but it says something about the way we talk about science and health. So so I just want to make that statement. I want to move forward. Lived experience, this is the way that I want to explain it, okay? Because as a CHW, what Tribeca and I have to do is we have to bridge. We have to take some of the most complicated stuff that we are exposed to. We have to sit with the epidemiologists and the oncologists, and we have to break this thing down for everyday people who are trying to live their life. These people, oh, by the way, have no place where they can learn about health. Not in grade school, not in high school. What course did you ever take to help you understand the healthcare system? There's barely a health class right now. Okay, I'm 55, so I remember when we had health class. Folk don't remember that. They don't have access to that. Okay, so you're dealing with folk who are just trying to live their life. When their arm starts falling off, they're like, something's wrong. Okay, but this is the way I want to explain this interplay between specialists, people who have real expertise that we need, technology, and everyday people. I want you to think about being in your house, and I want you to think that water starts pouring out of your kitchen all over the floor. You know you need a plumber. You don't even know what the problem is. You're like, I need a plumber. You call somebody, and let's just say this is the first time you've ever called this plumber. All right, so, you looked him up or whatever, you got some number from your neighbor, and the moment happens when the doorbell rings. Okay? Now, you're in the house. Maybe the kids are there. Maybe you're by yourself. Whatever's going on. Who knows what's going on? You're in a wheelchair. You got no food in the house. The kids are running around. Somebody's sick. You've had a negative experience. You've been raped. You've been beaten before. You've been jumped in your neighborhood. The plumber on the other side is a man, you're a woman. Or he's Black, you're white. Or he's white, you're Black. And you have to open up your door to the plumber. Because if you don't open up your door and let that person into your most personal space, the water keeps pouring out. I want to paint a picture for you. There is expertise that you need on the other side of that door. But that doesn't mean that plumber can just come in your house and not expect you to say, now, what's your name again? Can you show some ID? Because I want to make sure that the person coming in is not an impersonator. And I'm going to stand in the kitchen and watch you. I may not understand all that you're doing, but I sure as heck don't need a bill of $1,000. When I called, they said it would be $150. So I'm going to ask you some questions about your work. You don't get to just tell me I'm the doctor. I'm the plumber. I'm going to ask you some questions. You're going to show me your ID. And if it's me, Denise, we're going to stop at the door and have a little repartee. We're going to kick it for a minute because I want to know who's coming into my house. You might be coming to get this check, but I want to know. Well, so do you live around here? What? Just tell me yeah, I got your number from Mary. We're going to have some interaction. Because if you don't show me respect, you're not coming in the door. And I'm telling you, I'll call another plumber. The reason I'm trying to break it down simply is because we need to think about this exchange differently. We're not talking about it the way everyday people experience accessing the healthcare system. And Tribeca and I, and probably many of others of you, you help your family members, your neighbors, your elders. You yourself have to navigate the system. It can be scary. You can feel powerless. There's language you don't understand. You don't have time. You want to go to work. You don't have time. You got to bring the kids. It's already a burden. And you got to pay the copay or the deductible or the coinsurance. And you don't even know if you're going to get better. And you don't even know if the doctor's going to look you in the face because they're so busy looking at the laptop, putting the information in. And they're going to refer you to somebody else. And you may not even get the lab results for a week, 2 weeks. You got to go home anyway and still feel bad. There's so much complication in this system. And these philosophical conversations we are having is why we have generational poor issue.
Denise, thank you. I think we've heard that the way you describe that, we have heard that echoed through so many people's conversations that they've had interfacing with the system, over the past year that we've been having these conversations. I really appreciate you sharing that. I'm going to go to Alexandra, and then I think we're going to wrap it. We're going to kind of wind it down after that because it's almost 1:30. Alexandra, you had some thoughts.
Yeah, I just want to chime in about, as we talk about lived experiences and shared experiences and how to parse through the varying degrees of lived experiences and who do we rely on, who do we not rely on. The one thing I want to acknowledge too is like specifically with Black women and any group in particular that we're looking at, no one exists in a monolith. And I think like one of the things I wanted to mention too, as we were talking about self-advocacy, like I would say, as growing up, like I had a pretty decent experience with the healthcare system. Like I'm a childhood cancer survivor. My mom was my biggest advocate growing up. Like I didn't really feel like any struggle with the healthcare system up to the age of probably 17. And then when I had to start doing stuff myself, it was the most overwhelming thing that I've ever experienced. So like it got to a point where like my experience was I had this network in like little system around me from 8 to 17 where like everything was peachy and fine. And then on my own, trying to figure it out myself, that was my lived experience of like now I'm an adult at the age of 18 in DC by myself. This is completely new. Doctors aren't listening to me. I don't know what to do. My mom is still my biggest advocate. I can pick up the phone and call her. That's my privilege, and I'm thankful for that. But that's not everyone else's experience. So knowing that I'm able to use kind of like that experience myself and look at like what my family's gone through, the history behind like my parents in Louisiana and those health disparities, and like that's an experience I like to share and just talk about, why my journey in public health and what got me here. But like I also want to be cautious of us like putting everyone in one bucket and making it seem that like we are all the same and everyone's had the same experiences and we've come to this conclusion that we're all experiencing the same things, and in reality like lived experiences, no matter what the varying degree are, you can take one piece from everyone's experience, no matter what political spectrum, no matter what community, and have some sort of productive conversation and learn something that can push us forward to wherever we're trying to get to, which is obviously trying to be a more inclusive and honestly accessible healthcare system. I feel like that's kind of it's easier said than done, but honestly, it shouldn't be that hard to get to. So that's kind of where I wanted to leave us off at, I guess. Yeah.
Thank you for that, Alexandra. I want to really, first of all, just take a moment to acknowledge what an incredible conversation this has been. I know that it's often not easy. Like whenever we do these, we often leave being like, I don't know. I have lots of feelings, you know. I wanna frankly what I've heard us all say all, you know, for the last couple of hours is there are places where the system has absolutely shown up, and there are lots of places where the system needs reform and radical reform. And too often we rely on the goodness of people like Dr. Keisha to hold us all up. But the truth is, you need a system to make lots of Dr. Keishas out there. And also the community partnerships we build through CHWs, you know, is essential work. And having a government and an administration that really sees and elevates these types of stories is essential. So I want to thank all of you for joining us on this episode. To MacKenzie Isaac for dreaming up yet another fantastic idea. Thank you, Kenzie, Dr. Keisha, Tribeca, Denise Smith, Renee Mitchell, Jacinia Muhammad, Alexandra Thompson. Huge, huge thank you for joining us today on Why Should I Trust You? So that is our episode today. I am Brindata Kari. He's Tom Johnson. She is Maggie Bartlett. He is Dr. Mark. And that was and that was MacKenzie Isaac, who joined us riding shotgun with us as a co-moderator. Thank you so much. And we will see you right back here next week.